Welcome, colleagues. Welcome, everybody. We had a great day yesterday, a very productive day. We learned a lot from countries. We have seen, great progress, encouraging start, and countries at different levels of scale up of special care unit for in their respective countries. That was really motivating. So I hope we'll have another great day today. So since we may have new participants, let's quickly review the meeting rules. For those of you it would be second dose. So due to really the large size of this meeting, will not be able to have individual introduction, but you can greet all of us in the chat box. And please rename your profile to include your country name. This is going to be very, very important today because we'll be working in our country groups. So for you to be allocated to your respective country groups, we should be able to see your country. So write your country before your name. So to do this, you just click the participants icon. Now we are at 115. Click on the participant icon, you will see your name. When you put the cursor on your name, you will see two options, unmute, more. Click more. Then it will give you the option to rename your profile. Then if you are from India, India Rajesh Mata. So that is how we should do it. We can easily identify and we'll be able to assign you automatically to your respective country groups without wasting time. And then in order to have good discussion and avoid the echo, please remain mute unless you are given the floor to speak. Lastly, since we are many really to get the chance to speak, we would like to encourage everybody to use the chat box to make your contributions, your questions, and also responses. So we want you to be active in using the chat box. I think these are the few rules that I want to remind you. Next slide. Yesterday, this was the agenda for yesterday. We have covered all these agenda items successfully, although we were a little bit behind time, but it was it. And we have learned really a lot from each of the country presentations. And we are very, very grateful to all presenters and the team who have put a lot of time and effort to make those great presentations to share their country experiences. Next, please. So today, today's agenda we have slightly modified to accommodate the outstanding question and answer session of yesterday. So we'll spend about 10 minutes to respond to a few questions. There are not many actually, about 7 questions. So I would like to request the presenters to be standby and open their video. Dr. Yared from Ethiopia, Dr. Misandani from Malawi, and Dr. Kenny from Sierra Leone, and Dr. Jessica from Uganda. Can I see all of you? Can you wave your hands if you can see me? Okay, great, great. Thank you so much. So let me go in the alphabetical order. We have just a few questions. So for Ethiopia, in the area of workforce, is staffing an issue, particularly the nursing cadre? And how have you managed the issue of staff rotation, trained staff from Mnicu to other areas? Maybe let's just address this and then we go to the next one. Dr. Yared, you have the floor.
Thank you, Dr. Teshoma, and greetings to all from all around the world, yes, we do have issues with staffing, particularly with the neonatal nursing staffing. The clinical nursing staffing is relatively well staffed, even though there are frequent rotations and also, of course, leaving the public domain to join the private and other sectors. So as I have tried to explain yesterday, the main scheme is to retain for at least a year following the long duration of training on neonatal ICU, which used to be for 28 days. Once they are assigned back to their respective hospitals, they are expected to meet this agreement with the respective hospital management, even though this is not a legally binding agreement. This is an admin. Yeah. The other issue is some of the hospitals and some of the regional states have the incentive package, such as the hardship allowances that they provide, even though it is still not adequate that much. Some provide housing and the likes. Otherwise, there are issues with untrained neonatal ICU staffs joining or being assigned to the neonatal ICU, not only during regular hours, but also during the weekends and the duty hours. So we have observed that this really occur during the night duty shifts and also the weekends and the holidays. So it differs from facility to facility. We do not have a uniform retention mechanisms. So the sustainable way out is to have more and more of these specialized nurses, neonatal nurses, which we are having at bachelor's and slightly at master's level. These are the short-term and long-term interventions that we are just rolling out very recently.
Thank you.
Thank you, Dr. Tashoma.
Thank you, Dr. Ara. Thank you. So the second question is about maintenance. Ministry of Health, in collaboration with UNICEF, had procured huge quantities of equipment. And then maintenance is really anticipated to be a challenge. And then the question is, how are you managing the maintenance of this equipment? Dr. Yared.
Thank you again. This is also one very challenging area with the automation of neonatal ICUs these days. So we did procure 80 hospitals, level 3 neonatal ICU equipment, around 34 items ranging from pulse ox to ventilators. So we did have challenges, but what we did was, first we had this robust procurement system of the UNICEF. Otherwise, the one we usually do through the pharmaceutical supply agency, the government agency, would not have been that much really fast and rapid enough. So along with this special flagship project, there was trainings that were rolled out along with the installation and capacity building outsourced to local representative organizations outsourced by UNICEF. And they have provided on-site trainings, both training of trainers and also basic trainings on-site at every hospital, at every 80 hospitals. So the sustainable way out we are looking through this is to have the pharmaceutical and medical equipment directorate, which is a separate directorate that we are having to take over and continue with mentorship and site level preventive maintenance activities. For the time being, we do have a 4 rounds of preventive maintenance agreements that were outsourced, and we are in the second round. So they are going or moving around the country to demonstrate on how to provide preventive maintenance, cleaning of filters and the likes. Otherwise, this is really a very big challenge, and we still need to work in this area. This is not a clinical or a program activity that should be led by us, that we believe that this should be led by the respective directorate, where biomedical engineers and technicians, and they do have the structure down to the facilities. So the program side, the newborn and child health program side, would not be really in a better position to roll out this preventive maintenance or also curative maintenance skills. In one of the hospitals I visited, there were innovative approach that they used local university engineering department students, where they come on Thursdays to provide free service of maintenance activities, especially for oxygen-related equipments. So these are some of the options. Otherwise, this will definitely be a challenge for neonatal ICUs across the country. So we are working together with that directorate to have a structure that should be responsible and responsive enough to act whenever preventive maintenance and curative maintenance is requested by respective hospitals. Otherwise, very critical question, really a very challenging area in the area of neonatal ICU. Thank you, Dr. Tashu.
Thank you so much. Thank you very much. Would it be strategic to link with, I mean, some of these universities with a vendor or with a supplier, so that you build capacity in one of at least these institutions as a center of excellence to provide subsequent maintenance, training, mentoring, supervision, and so on. Just food for thought. We have another question which is related with the first actual question. Are there efforts to provide professional growth opportunities for neonatal nurses in Ethiopia? I wondered why they needed to sign an agreement. Would they just rather move on? Broad questions to all participants. How do we motivate and retain trained neonatal nurses? So Dr. Yared, you can respond as much as you can quickly, and the rest of the panelists can also address, because this is for all of us. Thank you. Over to you.
Again, for this very critical question. So, as we all know, neonatal ICU is not really a place comfortable enough to work 8 hours shift. So there definitely need to be a motivation mechanism, be it financial or other non-financial recognition mechanisms. So we do not have a national base or a national system to do this, but locally there are different options that hospitals are providing to the facilities. But without having this one-year agreement, having this training for 28 days, and if they are left on their own to choose to join other departments and the likes, then it will be really a waste of resources, hard-gained resources. So there should be a mechanism, and there should also be these allowances and other, from the simple coffee ceremonies, water and the likes, to showering and others, housing allowances and the likes, to as it was mentioned, to the level of professional career development. So we do not have a standardized career development in this regard, but because it is based on competitive approach, once they are trained, they are not really in a better position, or they are not really entitled because they do have this training. They have to compete based on their professional level and the year of service and the likes. Otherwise, there should be tailored motivation and incentive mechanisms. That is what we believe, and that is what we promote during our quarterly meetings with the CEOs of the respective hospitals. Thank you once again.
Thank you very much, Doctor. Thank you. Maybe others can come back to this later. So now I move to Malawi on the referral issues. Are you using standardized referral forms when you refer newborns? Dr. Mesandani, over to you.
Yeah, thank you very much. There's a new neonatal admission form that was created by the team from the Ministry of Health, and it is a standardized form. It's present in the districts, but also in the central hospitals. And it is the same form that we have used to create our database from. And so it speaks into both the paper version of data collection and also the digital form. Just to speak into the motivation of the nursing staff, I think for Malawi, already just creating that formalized way of training is a step one to motivation. because initially we've been using the general nurses. So what should stimulate somebody to move the nicer, quiet wards to come and work in a heavy and busy NICU? I think the fact that we're now going to formalize it and give them a certificate of training, that's already step one to motivation, and people are feeling excited about that bit of things. Indeed, we have to look into long-term, how best do we, after they then graduate, do we then keep the momentum going? But I think already giving them that formalized training is the motivation.
Thank you. Thank you very much. Maybe let's hear also from Dr. Jessica and Dr. Kenny on the motivation issue, because this is key. Staff motivation and retention is key for us to provide quality care. Huh? Any reflections? Okay, let's move on then to Sierra Leone. Are the PDSR review meetings taking place in the facilities or at subnational level? Dr. Kenny, how about you?
Hello, can I come in, Doctor? It looks like Dr. Kenny has not joined us. I'm Asha from UNICEF.
Okay, please go ahead. Thank you. Thank you.
Okay. Yes, just to answer the question, PDSR has only been implemented in the hospital where the special care baby units has been the intervention has been implemented. So it's not below that, yeah, for the PDSR.
Mm-hmm. Okay.
And for the motivation, just to add on that, yes, as Dr. Kenny had already mentioned, we do have quite a number of volunteers working in the SCPUs. So the small incentive that they are receiving, I think that's also a way of motivating them to do the great work they're doing now. And the post-basic nursing training package, neonatal nursing package, which is going to, is envisioned that it will be starting from next year. That is also another motivation for them. They're all excited about it, though it's going to be in batches. And the good part of that is, like, I think the government has also looked at their scheme of work. Once the nurses who take this training, they will get certain level, a level little higher than their counterparts. So I think that is also another motivation that is really driving them. Otherwise, as our previous speaker said, the work in the SCPU is really intensive compared to the other wards. So it's sometimes really difficult to retain this service provider, nurses especially. So that is one thing. And of course, the other part which the government has done in Sierra Leone was, initially when we started off, we had about 20 to 30% of them were PIN coded, remaining were all volunteers. But later they took a drastic step on giving PIN codes to these nurses. So that was also a very motivational approach to retain the nurses in the SCBU. But of course, we have another challenge. Once they get the PIN code, they want to move out. So that is definitely a challenge. I'm sure other countries are also facing that. However, that was also a motivational factor that really helped us to retain our nurses in the unit. Thank you.
Thank you so much. Thank you very much. This is very interesting to learn from Sierra Leone. I think we are running out of time. The last question which everybody can think about was, are countries doing longitudinal tracking of small and sick newborn, especially on developmental milestones, disabilities and learning? So this is a question for all of us. So in the interest of time, I think let's think about it, but let's move to the next agenda. So the next agenda would be presentation from Brazil and Argentina. I will invite Dr. Hema to take over the floor. Thank you so much. Thank you. Have a great day.
Greetings, everyone. So nice to have the opportunity to be here. It's a great privilege to introduce our next speakers as we travel around the world to Latin America. And first, I'd like to welcome from Brazil, Dr. Zeni Carvalho Lamy from the Federal University of Maranhão. a child health consultant and from the Ministry of Health Brazil, as well as Dr. Maranea Vale, who is the chief of the Neonatal Intensive Care Unit, also from the University Hospital of Maranhão. And you have 15 minutes, please. Thank you so much. Dr. Maranea, I believe you are on mute.
Yeah, she's muted, yeah.
You are still on mute. If you can unmute your computer. There you are.
Ok? Estão me ouvindo?
Perfect.
Ok. Então, a professora Zene Lamy não pôde comparecer porque teve uma intercorrência familiar e nós vamos falar aqui um pouco da nossa experiência aqui no Brasil. O Brasil é uma população de 210 milhões de habitantes, é um país muito grande, com muita diversidade, muita diferença entre as diversas regiões, e tem uma mortalidade infantil de 13,3 por mil e uma mortalidade neonatal de 9,9 para mil. Tem um total de nascimentos de 3 milhões de bebês por ano, onde 8,4% mais ou menos são bebês de baixo peso. No Brasil, nós temos o método canguru como uma política nacional de saúde desde o ano 2000, quando foi incorporada como política nacional, através de portarias. A unidade neonatal ela é dividida em UTIM, unidade de alto risco, uma unidade de cuidados intermediários e uma unidade de cuidados canguru. Então, é uma política nacional de saúde, o método canguru. Eu vou repetir o que eu falei. Na verdade, a portaria ela distribuiu unidade neonatal de alto risco, unidade de cuidado intermediário e unidade de cuidado intermediário canguru. Próximo. Pode passar, por favor. Então, no Brasil, essa política nacional do método canguru, ela distribuiu em centros de referência de acordo com a região do Brasil para que essa implementação se desse de uma maneira efetiva. Como o Brasil é uma região muito grande, nós temos 5 centros de referências nacionais distribuídos nas diversas regiões. O próximo. Pode passar, por favor. Então, cada centro de referência nacional, ele é responsável pela descentralização da formação de diversos profissionais em todo o país. Como é feito essa descentralização? É feita através de treinamentos. Esses treinamentos, eles ocorrem através dos consultores nacionais de cada centro, e através de sites. Tem o portal de boas práticas do Instituto Fernandes Figueiras, da Fiocruz, e também tem a portaria, tem o site de monitoramento de tudo que é feito através desse portal. Existem também diversas publicações do método canguru direcionadas para os profissionais e também direcionados tanto para a atenção hospitalar como para a atenção ambulatorial na unidade básica de saúde. Além das publicações, que estão todas disponíveis nesse link que a professora Zene colocou, e também no Ministério da Saúde, nós temos a estratégia Qualinel, que foi uma estratégia lançada para atuar naqueles estados da federação. E o que diz a estratégia Qualinel? Ela lançou, então, 4 passos depois dessas publicações. Próximo. Então, esses passos são, primeiro, Siga as normas de reanimação neonatal e evite a hipotermia, que é uma das causas de mortalidade infantil. Use a técnica do CPAP na sala de parto e diminua a possibilidade de entubar os bebês. Evite a hiperóxia, controle o uso do oxigênio. Os bebezinhos também, dentro do possível, alimente o bebê o mais breve possível após o nascimento para evitar que ele fique em dieta zero e que seja com leite materno, de preferência o leite da própria mãe. Higienize suas mãos para evitar infecção, reduza o uso de antibióticos, use todos os medicamentos, mas evite usar aqueles que podem causar alguma lesão no bebê. Pratique o método canguru, pratique o cuidado individualizado ao bebê e sua família, tudo isso para evitar que o bebê tenha mais complicações. Próximo. Próximo, por favor. Certo, era a fala da professora Zene. Agora eu vou começar a apresentação do nosso Centro de Referência Nacional, que é o centro da Universidade Federal do Maranhão, que fica no Hospital Universitário. Próximo. O nosso hospital é um hospital referência de ensino, ele fica no estado do Nordeste, uma região muito pobre do país, tem uma população de mais ou menos 7 milhões de habitantes, e a mortalidade é uma mortalidade alta, é 22,4%. Comparando com outras regiões do Brasil, ele é uma mortalidade bem alta. Ele é um centro de referência tanto para a gestação de alto risco, como para o método canguru, é um hospital amigo da criança, ele tem um parque tecnológico próprio, tem a sua forma de gestão também é própria, tem equipamentos suficientes para o atendimento terciário. Os seus profissionais são treinados em reanimação neonatal, tem pediatra na sala de parto 24 horas, eles praticam as boas práticas, que é o clampeamento do cordão em tempo, o contato pele a pele, o aleitamento materno na primeira hora. O próximo. O próximo, por favor. Pablo, pode passar o próximo, por gentileza? Isso. Então, nós temos a unidade de alto risco, como vocês podem ver, tem a presença da família com o bebê no contato pele a pele. Nós temos também a unidade neonatal intermediário, onde a mãe fica 24 horas, e nós temos o acompanhamento no ambulatório de segmento dos recém-nascidos pré-termos. Próximo. Próximo. The next. Então, o que é feito nessa unidade de terapia intensiva neonatal? São 20 leitos de terapia intensiva, são 12 leitos de unidade de cuidado intermediário, são 10 leitos de unidade canguru, trabalha uma equipe multiprofissional, trabalhando de forma interdisciplinar no cuidado ao bebê e sua família. Essa foto é no follow-up dos bebês, onde também atua uma equipe de forma multiprofissional, trabalhando de forma interdisciplinar e provendo também visita domiciliar quando é o caso. O foco da nossa unidade é o cuidado humanizado, respeitando a individualidade, a subjetividade de cada bebê, o próximo, e sua família. Então, esse é o bebê no contato pele a pele. A equipe toda ela é focada na recepção, no promover o contato pele a pele, no envolvimento da família com os cuidados do seu bebê, garantia de aleitamento materno, favorece as reuniões familiares de forma que essa família possa participar do cuidado. É uma unidade terapêutica do cuidado e também dá um suporte social para esse bebê. Nós temos um time de pediatras, de neonatologistas, diariamente, de plantão, tanto na unidade neonatal como na sala de parto. Temos uma equipe multidisciplinar, com terapeuta ocupacional, fisioterapeuta, fonoaudiólogo, e também temos os residentes e uma equipe multiprofissional de residentes. Nós temos residência multiprofissional em terapia ocupacional, em fisioterapia. Então, nós temos uma equipe bem completa. Próximo. Nós temos as visitas, no que elas se resumem nas atividades da UTI. Nós temos uma visita dessa família à unidade antes do bebê nascer, quando elas estão internadas na enfermaria de alto risco. Nós temos uma equipe multiprofissional trabalhando junto, nós temos o cuidado individualizado para aquele bebê e sua família, nós temos as visitas dos avós e dos irmãos com horário marcado para eles interagirem também com seus bebês. Nós temos encontro com as famílias e nós temos reuniões para promover aleitamento e reuniões também pós-óbito quando ocorre na unidade neonatal. Próximo. Além do cuidado humanizado, próximo, next. Além do cuidado humanizado, individualizado, nós temos algumas estratégias para a segurança do paciente. Uma delas é o Safety Huddle. Nós temos diariamente essa reunião onde a equipe multiprofissional se reúne com checklist para observar quais as dificuldades da gestão e do trabalho naquele dia. E as situações em que não podem ser resolvidas nesta reunião, que é uma reunião rápida de 10, 15 minutos, então é passado para um outro nível de gestão, se for o caso. Next. Então, o que a gente vê nessas reuniões? A gente vê o estado da nutrição, assistência ventilatória, os acessos, CVC, PIC, catéter umbilical, o cuidado de neuroproteção, a colostroterapia, fototerapia, analgesia, contato pele a pele, o uso de medicações, os bandos que são estipulados para uso de catéter ou para outras práticas, e o manejo dos riscos. A cada risco existente, a vigilância é acionada. E nós também temos o treinamento das boas práticas ao nascimento, a ressuscitação, os cuidados intensivos. Então, tudo isso é observado nesse Huddle. Next. E nós fazemos, como é que nós fazemos o monitoramento? Próximo, next. Como é que nós fazemos o monitoramento desse? Nós temos os indicadores, que são, o primeiro indicador é a mortalidade neonatal corrigida, né? Nós temos uma meta, que é 10%, que é baseado na literatura. Nós temos a taxa de infecção hospitalar, que nossa meta é 15%. Nós temos o índice de pneumonia associada à ventilação mecânica, 2%, e nós também temos um novo indicador que é o número, a prevalência da hipotermia dos bebês menores que 34 semanas admitidos na unidade neonatal. Next. Em relação à hipotermia, nós temos uma experiência muito positiva utilizando estratégias de qualidade como o PDCA. Nós tínhamos uma hipotermia muito elevada, em torno de 75%, e nós conseguimos reduzir para 14%, utilizando utilizando a estratégia do PDCA e utilizando os treinamentos e o checklist. O que era o checklist? Next. O checklist era feito em conjunto, sob a forma de pacote de medidas ou bundle. O que você tem que ver? A temperatura da sala de parto, mantida em 23 e 26 graus Celsius, a temperatura materna 15 minutos antes do parto, receber o bebê em campo aquecido, posicionar o bebê na fonte de calor radiante, usar o saco plástico, usar a touca dupla no bebê, transportar a incubadora na temperatura entre 35 e 37 graus Celsius, medir a temperatura axilar com 5 minutos de vida e só retirar o saco plástico na unidade neonatal após a normotermia. Essas orientações todas elas foram colocadas nesse ano sob a forma de cartaz para que os funcionários, todos os servidores e as famílias tivessem uma maior clareza desse assunto. Next. Próximo. Por último, eu queria agradecer, deixar o meu e-mail Pedir desculpas pelo atrapalho da tecnologia. Esse aí foi nosso mês de novembro, onde tem a reflexão da prematuridade, onde esse ano nós trabalhamos a separação zero, bebês e mamães sempre juntos, família sempre junto, pai e mãe sempre juntos. Obrigada. Aguardo as questões.
Wonderful, muito obrigado. Thank you so much. A beautiful presentation from Brazil and describing quite a bit of really wonderful and innovative work at the and particularly in kind of closer to a level 3 neonatal setting. So thank you so much. Next, and I think Maranea also went into some of the follow-up care, and I believe we're going to hear a bit more about that from Dr. Patricia Fernandez, the coordinator newborn health area and perinatal and child health from the Ministry of Health in Argentina. Thank you so much, Dr. Patricia.
Buenos días a todos. Muchas gracias por la invitación. Próxima. Argentina tiene una superficie muy amplia con lugares superpoblados y lugares que tienen una densidad poblacional muy baja. Es una república federal que está compuesta por 24 jurisdicciones, 24 provincias, cada una de las cuales tiene a su cargo la gestión y la administración de los servicios sanitarios propios, basados siempre en los marcos normativos y legales del Ministerio de Salud de la Nación. Y a su vez contarles que el sistema sanitario está compuesto por 3 subsectores: el público, que es gratuidad, tiene gratuidad para toda la población, de la seguridad social y privado. La próxima. Les presento a mi país en el mundo. Próxima. Próxima, por favor. Este es el número de los recién nacidos, los últimos datos oficiales, de los cuales el 9% está compuesto por prematuros y el 1,1% está representado por prematuros menores de 1.500 gramos, los cuales contribuyen a más del 50% de la mortalidad infantil en nuestro país. La próxima. Este gráfico muestra la tendencia descendente de los nacimientos en el país, en gran parte debido a políticas públicas. Próxima. Acá vemos la importante disminución de la mortalidad infantil a través de los años, con políticas públicas adecuadas, con el lentecimiento en los últimos años, cuando logramos bajar a un dígito la mortalidad. Y al lado, si vemos, está representado el mapa de Argentina, que muestra la importante inequidad, la brecha que hay entre las distintas jurisdicciones, que va de 2,5 veces. La próxima. Algo similar. Próxima. Perdón, la anterior. Algo similar ocurría con la mortalidad neonatal, que representa el 67% de la mortalidad infantil. Bueno, volviendo al tema que me convocó, que es el seguimiento post-alta, la población a seguir de estos niños son niños y niñas que tuvieron factores perinatales de riesgo, como ser cardiopatías congénitas complejas, malformaciones quirúrgicas, encefalopatía hipóxico-isquémica. Próxima, y en especial todos aquellos nacidos con antecedentes de prematurez, haciendo foco siempre de los más pequeños. Próxima. Próxima, por favor. Desde una perspectiva de curso de vida, todo lo que podamos hacer durante la niñez va a impactar en el tránsito de estas poblaciones hacia otras etapas del ciclo vital. Estos niños presentan mayor morbilidad a futuro, de enfermedades respiratorias, cardiovascular, condiciones de salud asociadas a discapacidad en desarrollo y neurosensorial, y todo esto puede afectar la calidad de vida y van a requerir de estrategias diferenciales en educación, salud, recreación, que conllevan un fuerte impacto social. La próxima. Bueno, este es el checklist que se realiza o se debería realizar previo al alta de estas poblaciones. No voy a nombrar cada uno de ellos, pero saber que si fueron prematuros, que nosotros el alta se daría cercano a las 36 semanas, con ausencia de apnea, con saturación mayor o igual a 92%, con un peso aproximado de 2.000 gramos, siempre con buena progresión, apoyando fuertemente la lactancia materna como el mejor alimento para todo recién nacido, verificando la succión de eglución, cumpliendo con la ley, con las pesquisas audiológicas, metabólicas y fondos de ojo, según corresponda, con las inmunizaciones acorde a edad real de estos niños, y nunca olvidar el conocimiento previo de dónde van a estar estos niños, cuáles son las condiciones donde van a vivir este niño, y asegurar la provisión de las necesidades especiales de atención si lo requiere. La próxima. Bueno, continuando con las condiciones, con los checklists, tenemos checklist para padres también, y hacemos mucho énfasis en lo que es la educación y la información, porque esta redunda en menor cantidad de reinternaciones, en mejor vínculo, y la familia se empodera del cuidado de su hijo. Entonces realizamos talleres prealta para cuidadores, de sueño seguro y prevención de muerte súbita, de prevención de infecciones, de administración de medicamentos o tratamientos especiales, cursos de RCP para padres, lactancia materna, y tenemos un importante conocimiento previo con el programa con el equipo de seguimiento previo al alta. La próxima, por favor. Creemos fuertemente que los beneficios de un programa de seguimiento a futuro, que son para la familia, la asistencia y vigilancia de estos niños egresados de UCIN, el diagnóstico temprano y el tratamiento oportuno, la devolución de los resultados a las UCIN, a las Mnicu donde fueron asistidos, planificación de políticas de salud basadas en indicadores, y la promoción del trabajo en red. La próxima. Que vigilamos principalmente nutrición y crecimiento, neurodesarrollo en cuanto a cognitivo, conductual y lenguaje, y neurosensorial, todo lo que es audición y visión. La próxima, por favor. Bueno, cuando planificamos el proceso de atención, vayan por favor cliqueando qué población vamos a seguir. Próxima. Tenemos que ver cuáles son las estrategias para evitar la deserción, cada cuánto vamos a seguirlos. Lo seguimos hasta los 7 años, cómo se va a realizar la transición de estos niños por curso de vida hacia la adolescencia y adultez, cómo vamos a articular con su pediatra de atención primaria, dónde se van a realizar los estudios para diagnóstico y dónde se van a realizar los tratamientos indicados. Esto no es fácil si ustedes vieron cómo las inequidades que hay en mi país. Entonces, esto es un trabajo importante que es continuo, de mejora continua, que vamos haciendo a través de los años. La próxima. Bien. Estas son algunas de las políticas llevadas a cabo del Ministerio de Salud. Esto es del área de neonatología, y tenemos capacitación en servicio, realizamos recomendaciones con estándares para la atención de los recién nacidos para todo el país. Siempre decimos de ahí para arriba lo que quieran, pero no de ahí para abajo. Cuidados centrados en la familia y derechos al nacimiento. Tenemos un programa nacional de RCP neonatal para todo el equipo de salud que tenga contacto con un recién nacido, y también tenemos RCP para padres. Tenemos programas de estabilización y traslado de recién nacido de riesgo, ley de pesquisa neonatal obligatoria, metabólica, auditiva, cardiopatías congénitas por oximetría de pulso y reflejo rojo. Tenemos el Programa Nacional de Prevención de Ceguera por ROP, donde está estipulado el fondo de ojo según las edades gestacionales, la Estrategia Nacional de Seguimiento, el programa de enfermedad respiratoria en lactantes de riesgo, que desde 2007 hasta ahora se sigue realizando, la Semana de la Prematurez, y gestión de la información, utilizamos el sistema informático perinatal del CLAP OPS. Todo esto enmarcado en nuestro marco es la regionalización perinatal y el nacimiento de maternidades que cumplan con las condiciones obstétricas y neonatales esenciales. Argentina desestima, no categoriza unidades que no cumplan con CONE. La próxima. Esto es para contarle algunos de los insumos que se vienen proveyendo a través de los años. En el 2007, programa de prevención de infecciones respiratorias, que es palivizumab, vacuna sextupla celular, fórmula láctea de prematuros para los consultorios de seguimiento, siempre fomentando lactancia materna. Próxima. Se trabaja de 2010 junto a UNICEF en el cumplimiento de los derechos de los prematuros. La próxima. Se realizaron cursos de capacitación virtual gratuitos, que están gratuitos, en los cuales puede entrar cualquiera que desee, que es de seguimiento de recién nacidos prematuros, de enfermería neonatal en prematuros, de nutrición neonatal, de retinopatía, de neurodesarrollo en niños y niñas con antecedentes de prematurez, y de RCP para cuidadores de alto riesgo. La próxima. Estas son algunas de las normativas de seguimiento que tenemos en el país. En el 2003 se hizo la guía de seguimiento de residuos ácidos de alto riesgo. En el 2016 se publicó el manual de organización de un programa de seguimiento de alto riesgo, y estamos próximos a la publicación de la guía de práctica clínica de seguimiento de recién nacidos prematuros. Gracias al aporte de OPS estamos haciendo una adaptación de la guía de OPS. Próxima. Esto es para mostrarles del año 2017, capacitamos a todo el país en forma presencial y en forma virtual, y lo seguimos haciendo en evaluaciones de desarrollo para tener estándares en todo el país. La próxima. Próxima, por favor. En cuanto a redes de atención, tenemos un link que redirige al mapa de georreferenciamiento de consultorios de alto riesgo. Estos son del subsector público. Hay aproximadamente 90 consultorios. Cada carita feliz representa un consultorio de alto riesgo. Y hoy funciona muy bien el WhatsApp de seguimiento de alto riesgo, con aproximadamente 245 profesionales, con mucha seriedad, y diariamente, este WhatsApp está hecho principalmente para encontrarnos de una punta a la otra del país. La próxima. La pandemia nos trajo, como a todo el mundo, vayan cliqueando por favor, next, nos trajo amenazas en la continuidad de la asistencia integral de estos niños, con lo cual prontamente realizamos recomendaciones para el seguimiento de recién nacidos de alto riesgo. Hicimos un modelo de teleconsulta para los consultorios de seguimiento de alto riesgo, la anterior, bueno, y recomendaciones para el acceso a la atención de niños, niñas y adolescentes con discapacidad, entre otros, perdón. Esta es la página del Banco de Recursos del Ministerio de Salud de la Nación, que tiene acceso libre y gratuito para descargar documentos, algoritmos, y en la última diapositiva después les dejo compartido el link de acceso. Estos son los marcos legales en los que nos basamos y las normativas nacionales. La primera es nuestra Constitución Nacional, la Ley de Protección Integral de los Derechos Niñas, Niños y Adolescentes, el Programa de Prevención de Ceguera por ROP, la Ley Nacional de Screening, el Programa de Hipoacusia, el Nacimiento Humanizado, y una resolución 641, que es la resolución de funcionamiento de cómo tienen que funcionar las unidades de cuidados neonatales. Y lo último que se realizó es la ley 27.611, que es la ley 1000 días, que está en fase de implementación, que contiene la política de la prematurez. Próxima. La ley 1000 días se encuentra en la fase de implementación, es un modelo de atención integral de la salud en los primeros 3 años de vida. Próxima. Y dentro de esta ley está la política, como les decía, la política integral para la prematurez, específicamente el punto 4, que es prevenir discapacidad asociada a la prematurez, organizando la vigilancia de los riesgos, articulando los niveles de atención, siempre por medio de la regionalización y redes comunitarias, garantizando apoyos oportunos en favor de las niñas y los niños nacidos prematuros, centrados siempre en las familias y en las comunidades, y trabajar por el acceso a cuidados especiales de la salud en el marco de la clasificación integral del funcionamiento. La próxima. Próxima, por favor. Desafíos, muchos, entre los cuales tenemos que se pueda lograr la atención intersectorial integrada, la transición a lo largo de la vida, la plena integración social, el acceso a la atención sanitaria especial y a las necesidades sanitarias especiales, seguir con las campañas de educación comunitaria para así poder lograr una demanda calificada de la población, herramientas para identificar a las familias con mayor vulnerabilidad, creación y apoyo a programas locales, continuar con la regionalización de los servicios perinatal y pediátrico, el sistema de información digitalizado y lograr equipos interdisciplinarios federales. Próxima. Es una tarea de todos y entre todos. Muchas gracias por escucharme y les dejo la próxima, los links de acceso, link de acceso a todo lo que les conté. Muchas gracias por escucharme.
Muchas gracias, Dr. Patricia. That was a really incredible presentation of such comprehensive and important work in Argentina. And I think it
Gracias.
Apologies, I was muted. Thank you so much, Dr. Patricia. I think this was such a beautiful and comprehensive presentation, and so important to see both what we have to do today, as well as what we have to do for tomorrow, because we have to plan it right now. I think this was an incredibly important reminder that the entire goal is not just for children to live, but to live well, and we have to plan for that from the start. So just really wonderful to see. So, of course, as moderator, it's difficult that I have been tasked with having to try to manage the time. And there are so many incredible questions for such complex and important work from both countries. I'm going to try to just be a bit selective, but know that all of these questions are important, and the Secretariat is working to find ways to have all of the questions answered in due time, and perhaps in various post-meeting venues as well. But just to quickly thank you, Dr. Maranea, also for coming back on screen. I'll start with Brazil. There are a number of questions that have come up. And perhaps there are a few around quality of care and some of the structural ways and some more specific questions. One question that I think is very context dependent that I'd like to raise is a question that was brought up about what is happening in Brazil with early elective C-section, and is the rate coming down? Are there policies that are changing to limit and end this practice, knowing that they affect the outcome of the baby as well?
Para mim, a pergunta é,
Yeah.
nós temos uma taxa de cesariana no hospital universitário, que é um hospital público, ela é mais de 50%, mas, em geral, as causas não são causas eletivas. Como é um hospital de referência para gestação de alto risco, muitas das cesáreas são indicadas por morbidade materna ou risco para o bebê. Em nível privado, aqui no Brasil, nós temos um número, mas eu não sei dizer qual, em relação à indicação das cesarianas. Tem um número maior de cesarianas eletivas no setor privado, mas no público, pelo menos no nosso hospital universitário, ele ainda é elevado, mas há custo de morbidade materna ou risco para o bebê.
Thank you so much. Another question on, can you speak to the role of the National Neonatal Research Network in generating data and collecting context-specific knowledge on the improvement of care?
Desculpe, em relação, eu queria entender melhor, em relação à coleta de dados neonatais, é isso? Eu fiquei em dúvida em relação à questão. Repita, por gentileza.
Unfortunately, I'm sorry if you're asking me a question, I'm unable, the translation is not working for me, and I'm not understanding. I don't know.
Repeat question, please.
No problem. The question is if you can comment on the role of the nationwide neonatal research network in generating the data and collecting knowledge on improvement of care.
Okay. Gente, obrigada. Nós participamos, a nossa unidade participa da Rede Brasileira de Pesquisas Neonatais, onde são coletados dados de todos os bebês que nascem com menor que 1.500 gramas. Esses dados são utilizados para inúmeras pesquisas, tanto pesquisas locais como pesquisas nacionais, e nós publicamos. Hoje nós estamos aqui no Congresso Brasileiro de Perinatologia, onde vários trabalhos derivados da coleta de dados da Rede Brasileira de Pesquisas Neonatais são mostradas. E a gente espera que esses resultados dessas pesquisas cheguem até os gestores para que se transformem em políticas públicas de melhoria do cuidado, por exemplo, em relação à infecção, em relação ao transporte, em relação ao método canguru, ao contato pele a pele. E essa nossa coleta, essa nossa presença nessa rede brasileira de pesquisa, ela é muito importante na medida em que nós nos enxergamos, nós temos indicadores e podemos trabalhar sobre esses indicadores para tentar melhorar o cuidado.
Wonderful, thank you so much. There are still some more questions, but I think we're going to, for the sake of time, move on to some of the questions for Dr. Patricia as well. Dr. Patricia, there are questions around this regionalization and the networks of care that have been established, as well as some more specific questions around the technical aspect of which developmental tool is used. And lastly, I'll add one in around the HR and what type and cadre of staff is providing the interdisciplinary follow-up care. So I have combined, I think, 3 questions from the chat into that. And so hoping you can tackle them if that works for you. Thank you.
Perfecto, muchas gracias. Bueno, voy a tratar de ser breve. Con respecto a la regionalización, yo me aboqué a lo que era el seguimiento posalta, pero nuestro trabajo marco de todo el Ministerio de Salud de la Nación es la regionalización en todo, en lo que es prenatal, perinatal, dónde tienen que nacer estos niños. Hay redes creadas y coordinación para todo lo que es el traslado, que siempre se pondera el traslado del bebé intraútero. Nosotros tenemos regionalizado en niveles de atención, nivel 2, que es los partos de bajo riesgo, nivel 3A para menores de 35 semanas y mayores de 32 semanas, y nivel 3B para menores de 32 semanas. Con respecto, a ver, ¿qué otra cosa me dijeron? Con respecto a cuál era la evaluación que utilizábamos nosotros, el país es libre de utilizar la evaluación que, por ejemplo, si alguien que está utilizando el Bailey, está bien, no es que nosotros es mandatorio que tiene que utilizar un screening o un test específico, pero nosotros hemos hecho kits y hemos capacitado a todo el país con la evaluación de CAT-CLAMP, porque nos parece que es bastante simple y nos da una mirada en forma rápida de cómo están estos niños en todas sus áreas. Y con respecto, me preguntaban al tipo de personal, nosotros sugerimos fuertemente que los líderes sean pediatras y enfermeros. Sabemos que hay todavía, yo soy neonatóloga y también soy una de las líderes en seguimiento, pero hoy en día los neonatólogos sí, nosotros propiciamos a que estén en las terapias, pero que haya un líder en el consultorio que sea neonatólogo o pediatra, y después el equipo multidisciplinario o interdisciplinario, que es lo que más se da en nuestro país. Médico, enfermero, terapista ocupacional, la asistente social, que es fundamental para que funcione el consultorio, y después toda la interdisciplina. Fonoaudiólogos, todos los, como dicen los padres de nuestros pacientitos, todos los ólogos han aparecido, los fonoaudiólogos, los neumonólogos, todos. Entonces, nosotros lo que propiciamos es que todos los equipos, que no haya en todos los lugares equipos de seguimiento, y que estén centralizados según los niveles de regionalización, y que se deriven estos niños, que la atención de todos los meses se haga en el centro de atención primaria cercano a su casa, y que tenemos un planígrafo que, por ejemplo, el primer año cada 3 meses sean evaluados en los consultorios de seguimiento, en el segundo año es 3 veces por año, y a partir de allí es 1 vez por año hasta el ingreso escolar, que es los 7 años. No sé si respondí, quise ser rápida, pero...
That was wonderful. Thank you so much, Dr. Patricia. So many themes are emerging from the various country experiences and at different stages, and it shows a variety of paths along this journey of scaling up high quality care for small and sick newborns, as well as really following them into their journey into early childhood. So thank you so much. And now to help synthesize some of these lessons learned from across the globe, I welcome back Dr. Gagan Gupta from UNICEF, who will take on the challenge of starting to address what does it take to scale up facility-based newborn care. Gagan, over to you.
Thanks, Hema. And am I audible?
Yes.
Great. And are the slides moving?
Yes.
Great. So thanks, Hema, and thanks everyone and 200 plus people who are here today. And as we move for the next 20 minutes, I will try to go into the nuts and bolts of what scaling up of the facility-based newborn care takes. I would be building largely on the lessons from India, as well as the countries which we have listened till now. India, because it has reached already the ENAP target of 80% coverage, and the fact that I was involved in the journey for 12 years. But we have also heard a lot of interesting work from the other countries, and I will try to bring all those things together. Now, if you look at the journey of India, it's also a journey of pilot.
Sorry, Gagan, I will just interrupt to ask anybody who is not speaking to please mute yourself, or if someone on the admin side could mute anyone. Great, wonderful. Gagan,
yeah, muted. Yeah.
Thanks. So if you look at the SNC story of India, and it is also the story of not only India, but Bangladesh and many more countries which are still moving the journey, it takes time. It took 10 years for India to scale up from a multi-state pilot. So what's important is when you plan this, it's a journey and you need to know where you need to be going at the final destination. Plan it well and try to achieve the milestones as you go on this journey. Now, the focus initially in India in early 2000 was on community-based care, and so is the case in many countries. We had a strong IMNCI program. Whatever is the strategy in the community, be it IMNCI or any other community-based strategy, the key part of that is referrals. And referrals to where? Referrals often to a non-functioning health facility where newborns are lying below the fan, and you're just shifting the burden of mortality from community to facility. And this narrative is now shifting not only in India, but globally. In 2005, half of the women were delivering at home in India, but by 2015, nearly 80% women were delivering at health facility. So the newborns, instead of being born at home and in these huts, were moving to the hospitals. And this is what we are also seeing globally. In last 2 decades, there is a 54% increase in the institution delivery. But if we won't invest in the inpatient care, we won't be able to maximize the gains of facility births for the newborn survival. Now, what also India did well, which is also relevant for the other countries moving on this journey, is they defined the package of the facility-based newborn care and the different levels. Newborn care corners at all delivery points. At a sub-district level, they had a level 1 stabilization unit. At a district level, they had a level 2 unit, which had linkages with the medical college, and the kangaroo mother care, father care in the vicinity of the SNCU at all facilities. Now, there were 5 key prerequisites, and I will be speaking a lot about this as I go into my presentation. First is, as I said, define the levels of facility-based newborn care and ensure necessary funding. But once you have ensured the funding, put the clear budget lines in the national, state, and district plans. The second thing was the investment on the infrastructure upgradation and standardizing the designs of the newborn care unit. The third was putting in place a system for equipment procurement and maintenance is critical. The HR norms and huge changes in the HR policy to attract the needed human resources. And then making sure what's happening in these units, and when babies goes home from these units, what's the follow-up system. And lastly, you have to work simultaneously on these steps and not sequentially. Often we buy the equipment and then we think of the human resources or the infrastructure. But in the real world, you need to make sure that these things work simultaneously and not sequentially. Another important thing which India did was when they piloted it, they piloted as a multi-state pilot. The advantage of doing a multi-state pilot is you're bringing more stakeholders, you're getting more buy-in, and you are creating more competition between different provinces and states. And if you do only a pilot in 1 or 2 states or provinces, and if you hit the bottleneck and a roadblock, you're gone. But when you are doing a multi-state pilot, few of them will run with it. And that will set the example not only for that state and province, but for the other states to follow as well. Another thing was, even if the pilot is funded by a partner, it's important that as early as possible, the human resources and the running costs for that comes from the government. And what that led to was a multi-state pilot in 18 districts between 2008 to 10 to nearly 844 newborn care units as of 2019, and reaching the 1 million mark in a single year in 2018 with 1 million newborn admissions each year. This is the journey which took 10 years. Now, having given this background and what you heard yesterday also from Dr. Sumita and the India team, what will it take to scale up the facility-based newborn care in different contexts? Let's deep dive a bit into it for the next 10 to 15 minutes. The first thing, as I said, is you need to have a long-term vision. Where do you want to take your country in 2030? A 10-year journey. Some countries have already started it. Some countries will start it. But what's important at the beginning is bring a technical working group, which should be led by the federal government, but also engage the state government representatives and provinces in these deliberations. And at the federal level, also engage the biomedical department, as we heard from Ethiopia government, or engage with maternal health team, the community health team, because these are the components. Otherwise, you will be struggling later on. Partners are often engaged in pilot, but after advocacy, we are often guilty of withdrawing ourselves. It's important that if we have advocated for an intervention, we need to walk this journey together. The third thing is the role of professional bodies beyond advocacy in capacity building and supportive supervision is huge. The technical experts, and not only to talk about nurses and pediatricians, but you need to also bring the gynecologists, the engineers, the procurement, and the human resource people, because all these components needs to be addressed. And then the parents group to make sure that family-centered care is integrated. And as I said, resources may come from anywhere, but the government leadership is important to align all the efforts. Now, having said that and having set a vision, the second step is put in place a national plan with clear timelines. And this is one example from Bangladesh. In 2014, they developed a national strategy for scaling up SCANU. They have now achieved around 78% district coverage, but they put the vision in 2014 for a long-term strategy. One of the important components is, as I said, define the levels of care. Level 1 for sub-district, level 2 for a district level or an equivalent unit depending on the district size, and level 3 for the teaching hospitals. Ensure the essential newborn care and the kangaroo mother care is at all health facilities, and need assessment can help you to understand the gaps better. The second important thing is the plan should cover all the critical components of facility-based newborn care. There should be a chapter on infrastructure, on equipment, on HR, the quality improvement, the data systems, the follow-up care. And as I said, plan for a multi-district pilot to get the buy-in across the states. The step 3 is, once you have started putting the action on ground, bring your political leadership into it. Seeing is believing, and it's very critical to leverage both the policy decisions around HR and the funding. We saw yesterday one example from Sierra Leone, where the president of Sierra Leone visited the unit, and after that, it became easier for them to implement the policy changes. Same way, this picture on the left side of the screen is from India. One of the chief ministers, he visited the unit, and after that, in every review meeting, he was asking his team, what is the status of the new units which are coming up? Because he wanted every district to have a newborn care unit. So once you put the political leadership, because it's a very visible intervention, and political leadership likes to be associated with something which is visible and seems to be beneficial to the masses. The fourth thing is, once you have the plan and the vision, you need to make sure your plan is funded and very clear budget lines are there. Now, when you are doing budgeting, it's not a very complex exercise. Keep it simple. It's just an interplay of two things, the establishment cost and the operating expenses. You need to have a specific budget line for infrastructure, specific budget line for human resources, for equipment, for data systems. Reflect them in the district plans. Provision of running costs is critical. What is important is to get the bed strength and human resources right. Establish the costing norm for each component. And as I said, scale up is best done through government resources, but we know that in some countries, it will take some time for governments to invest that kind of resources. So a mix of domestic, national plus state and partner resources can also be used to secure funding, as we saw in case of Bangladesh, as we saw in case of Ethiopia, and as we saw in case of Sierra Leone. This is some of the examples of how you standardize the budgeting norms. This is from India. And if you look at the last column, which is the SNCU, there are two components. One is the one-time establishment cost. And the second component is, the first is the one-time cost, and second is the recurring or the running cost. And if you see that there is a cost for civil works, there's a cost for equipment, and nearly $80,000 were factored in 2013 as a one-time establishment cost. And around $20,000 were factored in for the operational cost for consumables and maintenance. So this is the way you need to make clear that the budgeting is done. Some more examples, if you see from Bangladesh, this is the list of equipments, the quantity of equipments needed, and the cost. And on the right side is the Sierra Leone Special Baby Care Unit, where they have said E is for essential equipments and then desirable equipments, and what should be the quantity. So once you standardize these things, and it's not rocket science, the technical working groups along with the partner support can come together. We have a lot of global resources available which we can share, and this can be done at the country level. Now coming to the next steps, and these steps, don't see them as steps, they have to work simultaneously, as I said. The infrastructure planning and standardization. Now, what are the key considerations when you look at infrastructure? The biggest question is whether you go for a new construction versus you renovate the existing space. And it has its own cost implications. New construction is more costly versus renovating the existing space. But what is important is you first identify what essential services you need to include in the design. You need a mother's room, you need a breastfeeding area, you need an inpatient care, you need a kangaroo care. Identify your essential services. Don't miss out labor room and the space for mothers. And then you develop a standard floor plan for different types of spaces, rectangular space, a prototype for a square space, a prototype for an oval space, and then try to see how many of those services can fit it and what extension of services is then required. Now, while you are planning the infrastructure, identifying the optimal bed capacity is very critical. Now, calculating bed capacity is a function of delivery load and the referrals you are expecting, plus the average duration of stay. Our experience from India for nearly 5 million newborns said that average duration of stay is 5 to 6 days. And then you see what is your number of deliveries to take the inpatient load and what are the referrals you are expecting from the other facilities and the community. Try to target for around 80% bed occupancy, because you also need to factor in for the population growth, which will happen in the few years down the line, and the potential to rise in institution delivery, especially in many parts of Africa where institution delivery is still 50 to 60%. A too small a unit might not be cost efficient, while too big a unit might be underutilized. The practical experience from the ground says that a 20-bedded unit can generally cater to nearly 1,000 admissions per year. So try to calculate what is the expected delivery load and then try to build your bed capacity accordingly. Now, this is a typical floor plan, but what is important, as I said, is when you are making a floor plan, identify the essential services. And what are the services, and we can deliberate more in the coming 2 days on this. A triage or the receiving room, the hand washing stations, the reception, the waiting area, then the patient care area, and we still need to fix norms for it. But the experience-based norms which were driven by India, Bangladesh, Sierra Leone, and Ethiopia, they have taken around 50 square feet area for the patient care. India even went ahead to add another 50 square feet area for the ancillary services. So if you have to have a 12-bed thing, around 600 square feet, plus some patient care area needs to be added. Factor in the step down, the kangaroo mother care, the breastfeeding support, the mother's ward, follow-up clinic, and counseling room. Some of these things like follow-up clinic, if there is no space, can be probably in the same area but outside the newborn care unit. And then you also need to have space for the oxygen room, the generator room, the store, the radiology and the side lab, the toilets, and the waste disposal. And as I said, a 20-bedded unit can cater to roughly nearly 1,000 newborns per year. But what's important is when you're making provision for the newborn care unit, do not disrupt the existing services. In case you need to relocate some services, please make sure you find alternative space for them before disrupting the existing work in the hospital. Because often it happens is under pressure, the hospital will empty a place which was already functioning either as a pediatric ward or a medical ward. So make sure that we are able to reallocate the space to the existing services. The next important component after infrastructure is the equipment procurement and maintenance. Easy to procure and deploy, but difficult to maintain and sustain. It's better always to group equipment as essential and desirable. We saw that in the list from the Sierra Leone, where they have listed the equipment, what is the bare essential things and what is desirable. And the ENAP communities group, as Lily said yesterday, would be now coming up with more guidance around this in the coming year. Initial procurement may be supported by partners, but down the line, developing domestic capacity for procurement and maintenance is very critical. Again, we need to standardize the specifications and establish the rate contracts in the long run. We saw in Ethiopia, the APSA is also engaged with that, though UNICEF is still involved in the procurement. In India, all the equipments are now being procured through government. Build the local capacity to repair. We heard about the biomedical technicians and engineers in Sierra Leone, Malawi, and Uganda, something which is very critical. Also have a 20 to 30% buffer stock, because there will be a breakdown time and it will take some time to repair the equipment. So when you're ordering the equipment, don't only order if you have a 20-bed capacity, don't just order 20 radiant warmers. Factor in a buffer stock so that when the equipments are down, you can use the buffer stock meanwhile, and include the training and the annual maintenance cost for 3 to 5 years. Don't forget consumables, generators, power stabilizers, cylinders, fire extinguishers, and the laboratory equipments. This is something from the UNICEF supply catalog. I've tried to put it because when countries do the procurement, they see it as multiple things, and we are also now trying to bring it together. So if you want to do an oxygen, what you need basically is either an oxygen concentrator or an oxygen cylinder or a PSA plant, and then the cannula, monitoring then effective use of oxygen, and then the gadgets which will prevent the breakdown like voltage stabilizers and surge suppressors are very important, because power supply in many of the countries is very unstable. If you don't put the surge suppressors and the voltage stabilizers, the equipment will suddenly receive a strong power fluctuation, and it puts the risk of both breakdown and fires. And its fire hazard is a real thing in the newborn care unit. Something about procurement and maintenance. Now, you see yesterday from Sierra Leone, a very good document on the National Policy on Management and Maintenance of Medical Equipment. And similarly, NEST has done some very good work on the technical modules for equipment repair. They also have the videos which are there on their website, which countries can use. So what we need is not only procurement, but a system for procurement which is country owned with domestic ownership, and a system of maintenance. The next important thing is the human resources. And this is, I think, the toughest pillar of all. Attracting and retaining human resource is a challenge, but there's no getting away from it. There is no single solution. You require a multi-pronged approach. The big HR dilemma for program managers is whether you redeploy the existing staff or you create new positions. Now, when you redeploy existing staff, you are already overburdening a depleted system. You are taking out a nurse from a pediatric ward or from a medical ward, which itself is very understaffed, or from a labor room, which is understaffed. You are bringing someone who will be working not to the full capacity because there are not enough people you can shift from one facility to another. What will it lead to is you are increasing the problem and deprivation in one facility, and the other facility which you are starting is also not fully staffed. That's why creating new positions is always better. Now, what is important is you may not get the people, but create the norms that we will have 4 medical officers, we will have 15 nurses. Create the norms for your country with your expert group. Reflect them in your plan and the budgets, and slowly move towards achieving them. You may get 4 out of 15 nurses to begin with, but after 3 years you will have 10 nurses. So what's important is have the norms, create the cadre, and then work towards it. Having good working conditions and open door policy really helps to attract and retain staff. Often when people need job, our recruitments and vacancies are not open, and I will come to on it on the next slide. And the political and bureaucratic commitment is crucial. Never ever assume that doctors and nurses are not available. They are scarce, but if you make efforts, you can reduce the gap. And I will give you some examples from India on the policy changes to address the human resource needs. The first thing they did was decentralizing recruitment from national and state to district level. And instead of doing interviews once in a year, they shifted to walk-in interviews on a particular day in every month. You can choose the first Tuesday of every month. Everyone who needs a job, be it a nurse or a doctor, can walk in. We need to get out of the old age practices of human resources if we need to attract the people for health sector. The pay package was revised to attract and retain staff, and in many cases it was merged with the private sector, and we even saw the flux from the private sector to the government sector. The difficult area allowance, if you see this newspaper clipping, this is from the biggest state of India with 200 million population, and they said, you quote, we pay. They had a high base salary, and then they added on top of it a difficult area allowance and the intensive care allowance. You have fresh postgraduates and the fresh nursing graduates. 2 years service bond was put for that, but they were posted in good places. Posting was given to them in their home districts. They were very happy to go back and serve in their own district. And once you had the contractual staff, there was a time-bound regularization plan, and retaining the trained staff, even if they underwent transfer after regularization, in the other district they were given SNCUs. The retiring age and the task shifting were the other things that were looked at. Now, another thing, which is what are the HR needs for the level 2 units? And right now we don't have the norms, and we will be working together on these norms after this consultation. But just to put for discussion, what you need is, you might not have a neonatologist everywhere, but a combination of a pediatrician and medical officers, with pediatrician being on call and medical officers being on site, can serve a large amount of function. Similarly, for staff nurse, you may not have a neonatal nurse, but if you have one neonatal nurse, you can make her the in charge of the unit, and she can groom the other general nurses working under her on the newborn care. You need the lab technicians and the lab to open 24/7, a data clerk to enter the data, the ancillary staff, biomedical technician, and then certain services can be at regional level, like pediatric surgeon. And Louis often talks about this, pediatric surgeon and developmental specialist. You can have at a group of SNCUs, the biomedical engineer, the pediatric surgeon, and the developmental specialist. And as we have all discussed, the staff for SNCU should be for SNCU and discourage the rotation. Now, having seen the components of infrastructure, equipment, and human resources, what's important to know is what's happening in these newborn care units and what's happening to the babies once they go back home. And that's why tracking performance and outcomes across units is critical. The first step for this is standardize what you record. Because if you have 50 units and all 50 units are recording different variables, you will not be able to generate a uniform report. So agree at a national level, what are the key variables you will record and track. Start with a paper-based system and aim to shift to a digital or a hybrid system, a system which is both paper-based and digital. Don't just keep the data coming. Please analyze the data and give a feedback. This should happen at the level of the facility. It should happen at the level of the state and at national level at varying periodicity. Use this data and evidence to guide the program actions, including a lot of work on the quality initiative improvement, which is going on, that needs to be guided by this data coming from the units. If you have limited resources for supportive supervision, invest on those units which are performing not so well, and select indicators to be linked to HMIS the way we heard from Uganda and Bangladesh. Now, you can't link everything you are recording in a newborn care unit with HMIS, but 2 or 3 high-level indicators like the mortality, the weight on this, the cause of death, these kind of things can go into the HMIS, while rest of the indicators are more for district level and used for the reviews. And I'm giving you 2 examples of the monitoring systems, one from India and one from Bangladesh. So on the left of the screen, if you see, there's a uniform data recording sheet which all units use. This is the admission sheet.
I'm sorry to interrupt. We're getting pretty far over time. If we can try to wrap up. Thank you.
Yeah, and this is the discharge sheet and simultaneous entry of the data which is happening in the units. Same thing for Bangladesh. You can see that they have uniform data sheets along with a dashboard and simultaneous data entry. And this data needs to guide action. If you see from India, 3 million babies who are admitted in the newborn care unit, the mortality in the outborn unit was much higher as compared to the mortality in the inborn unit. And that makes a case for the pre-referral care and the transport. Similarly, when the babies are discharged, they still have not gained the optimal weight. 27% of these babies were below 2,000 grams on discharge. And then you need to invest in the hypothermia prevention, feeding support, and the continuum of care. And that's why you need to put a system for the post-discharge follow-up. Survival in SNCUs only is not enough. Screening at discharge and the follow-up care both in community and facility. You may not be able to start screening for vision and hearing from the beginning, but what you can do is you can use your existing community worker to make the home visits. You can ask the patients to follow up at the health facility with what you have with, and then you go for the developmental delays and the other aspects. So we need to extend this continuum of care back to community, where they belong to and where they come from. And lastly, it's important not to leave the families. We need to engage families from the very beginning. And we saw examples from Vietnam and Sierra Leone, where even for very sick babies, they were giving intermittent or continuous kangaroo mother care. And that also needs the stay for the mother, the free food and toilets. There are few areas which I have not captured, but we cannot miss in our radar. There are gender gaps in care seeking for girl child. We saw this in India, Bangladesh, and Sierra Leone. Care in the labor room impacts the SNCU admissions. Quality cannot be an afterthought. Quality needs to match the coverage. And lastly, we heard a bit from Argentina, the COVID impact on the inpatient newborn care. What's happening to the utilization? Follow-up is suffering, mother-baby separation, staff attrition, and the funding, because large part of funding also needs to be diverted to COVID response. So as I conclude, this is my last slide. What will help? I think having a clear vision where you want to be in 2025 and 2030. Adapting and evolving as you move forward. The model will automatically require and show you some gaps. And as you move forward, you need to adapt and evolve. Standardize the things and seeing more opportunities than challenges. Think big and act big. And lastly, be pragmatic and not cynical. Because to bring change, you need to be very pragmatic. And I will end with the quote which our former President of India often said, dream is not something that you see in sleep, but dream is something that does not let you sleep. And I'm sure the people who are here today and the governments and partners do nurture this dream. So let's take it forward. Thank you so much. And sorry, Hema, for being a bit over time, but I just wanted to bring everything together.
Wonderful. Thank you so much, Gagan. And such important points, and of really thinking about neonatal care as a full system and across the continuum and the life cycle and across the health system. Next, along similar lines and perhaps a different vantage point, will be Dr. Cyril Engman sharing a bit more on some case study work. Over to you, Cyril.
Thank you, Hema, and thank you, Gagan, for such an inspiring presentation. Can you hear me okay?
Yes.
Yes, we can.
Great. Okay, we'll go to the next slide, please. So I'd like to talk very briefly about a project that PATH is taking on at the moment. It's called the NeoLens project. It's lessons learned in establishing inpatient newborn care. And as we've heard throughout, the goal has been really to understand the approaches taken, the barriers and enablers, and what lessons and have we learned from the various countries where this project has been undertaken. So the countries involved were Ethiopia, India, Malawi, and Rwanda. And the key was really, and as we, again, the point I think has been made multiple times, that if we can understand better country level pathways, then as we move forward, both at funding level and at policy level, it'll help really improve and fine tune our thinking. A key component of this project was to put a framework around how different countries shared their experiences on their pathway to scale. And we used the WHO health system building blocks. We adapted that system to be able to document these processes and innovation strategies. Next slide, please. So this project is due to be completed in Q1 of 2022, end of January, beginning of February. And it has three components. There's a desk review component, which looks at all the peer-reviewed publications, all the gray literature that's available from the 4 countries, that's in the public domain. And then there are key informant interviews, which some were held in person, some obviously because of the pandemic were not. And there were semi-structured standardized questionnaires. The key informants themselves were key stakeholders in the 4 countries we've talked about: policymakers, clinicians, architects, engineers, anyone who's been involved in that in-depth understanding and development of the pathway taken to scale. And then there's a third component of this project, which is actually quite cool, and that's a virtual experience. And I'll make show a couple of pictures at the end, just to give you a flavor of it. But this sort of immerses the person who's looking at this work in a NICU. It's interactive. You can go into different rooms. You can click on icons where there are mini videos incorporated in this, so you can understand a better perspective, for example, the historical perspective, or for example, having a better appreciation of the kinds of technologies that are being used in that country. So again, really, really cool. And so watch this space for January, February 2022. Next slide, please. So as I mentioned earlier, these case studies are located in 4 countries: Ethiopia, Malawi, India, and Rwanda. And over the last 2 days, we've heard a lot anyway from our colleagues in Ethiopia, from Malawi, and from India. And we'll probably hear from colleagues in Rwanda as well. So see this as a bit of a synthesis and a bit of a summary, an overarching summary of what you've been hearing so far. Next slide. So to give an example, each case study has a initial barriers and challenges section. And again, to remind you, they're all contextualized around the health system building blocks. So for each country, we talk about leadership and governance challenges. Each country, there's human resources challenges. Each country, their health information system challenges, infrastructure challenges, service delivery challenges. Next slide, please. And then could I please ask if anyone is not muted to keep muted, please? And then
Please unmute, Cyril.
I see.
Yeah,
So
great,
each
thank
country
you.
case, thank you. Each country case also has a section on the journey and the vision that the country had at the very beginning. Next slide. And to Gagan's comment just before earlier, where he talks about you need to have a vision. You know, this talks about, so for example, Rwanda had a very clear vision of where they wanted to go, what data they used, what metrics they wanted to start utilizing as they move forward with that vision. So again, in these case studies, there's a vision for each country that has been articulated by all the stakeholders who we engage with. Next slide, please. As well, we share key events and moments from the 4 countries. So for example, these slides show you major key points for Rwanda in their thinking and evolution and journey map into scaling up care for the small and sick newborn. And I shan't go into all of this because you'll see it much clearer and in much more loving detail in January and February of 2022. And in addition to what you see here, there are also annotated annexes which go into a lot more detail about some of these events and timelines. Next slide, please. Now, this is where it gets really interesting because each country highlights the unique strategies and innovations used to strengthen their health system, whether it be Malawi we're talking about, or Ethiopia, or India. And so, and again, it's within the framework of the health systems building blocks. So let me give you an example. Next slide. So we've had a lot of conversations about human resources. So again, for each country in these case series that we're putting together, there's a section on what were the human resource strategies that were utilized. So for example, what were the goals of that strategy? How were they operationalized? You know, so for example, for Malawi, it was very much about using a mentoring system. It was about establishing learning sites in liaisons with the Ministry of Health and PACHA and trained staff. It was avoiding rotations of health personnel that had been trained in neonatal care. Again, a very, very topical issue that we've had so far. It was about regular meetings between obstetricians and pediatricians to review neonatal deaths. And the innovation, or one of the key innovations that we talk about, is implementing a COIN curriculum in pre-service training for all healthcare providers who didn't receive directed training on the small and sick newborn care. So again, just to make the point that these innovations and the strategies to get to the innovations are for each country, and they're for each of the health system building blocks. And I'm just using human resources as one example, but as we heard from Gagan in the previous section, along each of these health system building blocks, if you like, which for us was the organizing framework, there are numerous strategies and innovations that the 4 countries have share with us. Next slide. In Ethiopia, again, we heard yesterday that a big key was, how do you accelerate the healthcare workforce development? How do you improve in-service training and mentorship and continue professional development? How do you provide continuous support for healthcare providers and managers? And a key element which we heard yesterday and which we go into a lot more detail in the case series is around task shifting for the small and sick inpatient NICU. We heard yesterday, I think Dr. Yared spoke at length about how the task shifting had moved from doctors to trained nurses and how they'd set up system so that at least for 1 year, they would be in a position to work at this situation. Next slide, please. So for example, with Rwanda, again, just staying on one theme, which is human resources, a huge theme, of course. What were some of the strategies that were utilized to come up with an innovation for new cadres and staffing models, including partnerships with the Rwanda Pediatric Association? And again, we go into a fair amount of detail reflecting what was heard by key country stakeholders. Issues such as at the onset of this journey, there was just a sheer shortage of specialized staff. And so hiring such specialized staff, partnering with organizations who could then train specialized staff, task shifting to the general practitioners and nurses who rotated into neonatology and then received training. And of course, key amongst all of this were these strong relationships with obstetricians, gynecologists, pediatricians, National Council of Nurses and Midwives, etc. Next slide, please. And so to give another example, within each case study, we focus on what are the lessons learned and what advice do countries give. Again, building on what Gagan has just said, where he gives a lot of very practical, in-depth suggestions from India. These are framed from these 4 countries, again, along those lines. Next slide, please. So for example, from Rwanda, again, utilizing the health system building blocks framework, we talk about leadership and governance. And clearly, I think this has been illustrated time and time again, that it really needs strong leadership of the Ministry of Health or Health Service. In Rwanda, for example, lessons learned were that there were pediatricians in some cases who were ministers and who facilitated the advance of the agenda. But then without going into every single lesson learned, just highlighting again that the organizing framework of the health systems building block, which then talks about the human resources, the health information systems, the infrastructure. And under each of these, we reflect what we heard, which was what were the lessons learned at this point. Next slide, please. And then it concludes with advice to other countries interested in establishing care for the small and sick newborn. Gagan, for example, went into a lot of detail from India. In Rwanda, for example, these are some of the key comments that most of the Rwandan stakeholders agreed on were really important to other countries who are interested in establishing care for the small and sick newborn and then scaling it up. So using available means to get going. Don't wait until everything is in place, but actually start moving, have a vision, have champions, begin to think about how you can improve pre-hospital and emergency services to support care for those. Teaching mothers and the community about breastfeeding and nutrition, which we've heard of course, from our colleagues earlier today. Next slide. So from India, again, not to overly belie what Gagan has said, but these are some of the comments that stakeholders have made around, again, issues around leadership and governance and making sure that there's best practices that can then be diffused across the different states, making sure, for example, to engage the private sector, thinking through health information systems and how to strengthen those. And again, for each of those sections, the case series will go into a lot of detail about what has been heard, some of which you've heard of today, some of which just by the number of stakeholders involved in responding will be additional to what you've heard of as well today. Next slide. And then of course there's advice given, each case series has a section on advice given from the stakeholders to other countries. whether it's incentivizing staff with better remunerations and employment contracts, or whether it's sharing best practices across the states, whether it's equipment and maintenance and training local staff, that all those things are in these case series, which will be available in January of 2022. Next slide, please. So this is, when we started off, I mentioned that this project had three main groupings, if you like. The first was around the desk reviews of the gray literature and the peer-reviewed literature from each country discussing their pathway to scale. The second, which we've just gone through, are the key reflections that we have heard from all the major key informants in this body of work. And this bit is the area which I said I thought was very innovative and imaginative, because it actually takes the listener, the reader of these case series into a NICU virtually. It's an interactive process, a bit like in some museums where you can go in and tap on certain keys and start engaging. There are, for example, for people who've never been into a neonatal, a NICU, there are warmers, there are beds, there are little videos where you click on them, the little icons you can see there, you can click on them and they explain what they are, how they function. Next slide. These little circles, how you walk into and where you go into within a NICU. And these are real NICUs. And that door you can actually go through and then enter into a new, another room in a NICU. There are mini videos in there as well. And this is going to be not only aspirational and inspirational for policymakers, but eventually one can imagine a world where this becomes such a great global good that families in remote areas in an ideal world could perhaps even use a WhatsApp platform to be able to understand what a NICU might be like before they go, and actually strengthen the demand generation side of things. One can imagine a world like that. Next slide. This slide just illustrates the different, again, different aspects of a NICU, mini videos which are built into this virtual walkthrough, which again will be areas that can really help educate and provide more data and more information around NICUs in different parts of the world. Next slide. And so all the information hasn't been fully gathered yet for this project, but we've got some preliminary findings, which I think illustrate what we're hearing today, that at the country level, there's a lot of experience and scale up that has been going on already, but this isn't always well known, well understood, and sessions like this one, sessions like where we are learning from our colleagues are going to help illustrate that further. Now, some of these scale-up practices are not always in alignment, or they may be in partial alignment with WHO standards. So that's something to be noted for. And what's interesting to us is that as we've looked and been hearing and reflecting on what we've heard, it does seem as if the innovation strategies in many cases are uniquely distinct, actually. And these are innovation strategies in each of the health system building block domains that I had mentioned earlier. And so even though our goal here is to have a generic model, I think we need to have space to be able to give room for many countries' nuance and innovations that they're going to put in that are unique to that country. And it is becoming increasingly clear as we share some of this information with other colleagues in other countries and other stakeholders, that actually having a journey map for where countries are in this pathway to scale can be a powerful tool, both for planning purposes, for policy purposes, or even financial purposes. Next slide, please. So what would be the sort of next steps after this? I think all of us have touched on this and at multiple points continue to make the case that, you know, until we can in confidence make the economic argument, the cost-effective argument, you know, understand better the cost drivers, it's going to be very difficult to move many of these agendas along, because whereas most of us on this call are driven by the obvious need and of health and so on, you know, the tough decisions that governments have to make and having a strong understanding of the economic case can be a real powerful driver for any of these processes that we're talking about as we try to scale up. Clearly, we need to build up more country level experiences and document them more so that we can share more. There may be so many themes that are very, very comparable country to country, region to region, which will be tremendous learning for each group. Certainly, we need to rethink a little bit more about in really conceptualizing what inpatient newborn experiences can be and have a human-centered design, where rather than what tends to happen now, where as an afterthought, healthcare workers are involved or so on, that we at the very onset include parents and all the key stakeholders involved in this. And then clearly we've got to be able to, as we move into this much more concerted effort around facility-based and family-level experiences and family-centered care, really understand those experiences more to really create a higher demand generation, if you like, and also a stronger push towards quality. Next slide. So these last two slides are to the acknowledgements to the entire PATH team, the numerous contributors from the Ministries of Health, from India, from Rwanda, from Malawi, from Ethiopia, the various stakeholders, next slide please, who spent so much time, and there are some who are still making contributions. And this is to acknowledge that this sort of work and these case series, which are going to be coming up in January and February, are really an army of people, but the focus of them is exquisitely the country voice. That's the big difference here. And again, we're very, very grateful. So on behalf of that entire team of people who've been able to share this information and help us reflect about it, I'd like to say thank you. Over.
Wonderful. Thank you so much, Cyril. And thank you to Cyril and Gagan for such really wonderful synthesis presentations. Gagan, you know, sharing such an in-depth, practical, step-by-step journey map of the India journey and calling upon lessons that we've seen across many, many countries as well. You know, we are a little bit over time, and I don't want, and I know we're in the break period, and I don't want to take away from that. And so I'm going to just ask the chairs if it perhaps may make sense, since many of the questions that have been raised in the chat are more reflective, and some of them, there's one big theme around infrastructure. I think that component of Gagan's presentation and perhaps the inside of the neonatal unit virtual experience that Cyril referenced may be better deferred until the discussion on the Mnicu that is coming in the afternoon. It really is food for thought of whether the design of today will serve the needs of not even tomorrow already in some ways. So I think I am going to just ask the chairs if perhaps we should go ahead and move on to break and take these comments and questions as more reflective and address further in the afternoon.
Right, I think it makes sense. And most of these are more of comments rather than questions, so we can do that.
And I think they're very important, in many ways, the most important, but they're much better, I think, addressed in the small groups for deeper discussion, as well as in the afternoon presentations. We'll build on them. So really appreciate Gagan and Cyril for synthesizing in many ways the lessons, practical and thematic across many countries, and hopefully putting everyone into the mindset for a quick break, refresh your coffees, your energies, and come back, and Dr. Gagan will share the instructions for group work so that you can really dive deeper into the practical planning and thinking of that is needed, and get the support of your peers. Thank you.
So Hema will come back in 10 minutes, is that right? Or 5?
Unmuted.
Yeah, when will we come back?
Can we do it in 5 minutes?
Yeah, but
let's at 5 minutes after the hour.
Yeah, but let's make a few important announcements for the group work before we go for our coffee. And thanks for sharing the slides. So next, after the break for next 5 to 10 minutes, we will be reconvening in the groups. And the purpose of the group work is to start breaking the ice and starting discussing whatever we have listened for last 2 days. There are 2 tasks which we are expecting in the group work. It will be a more of an informal kind of a discussion. First is take a couple of minutes to reflect where you are as a country and your teams in terms of what we listen, what is required for the scale up of the facility-based newborn care. But more importantly, take time to see what you have heard for last 2 days. You have heard 9 countries, you have heard different experiences. What are 3 to 5 lessons that you have learned that you feel you can implement in your own settings while scaling up? And there will be no formal presentations, but the rapporteurs will be bringing all the thought process together, and that would be the part of the report. And this sets up well for the next group work tomorrow, where we will come together to see what are the key components that we agree upon as a community of newborn to make sure that that can be adapted and implemented at the country level. So this is the beginning. Take it just like a normal coffee chat, which we have in the physical meeting, but this time it's virtually. So please grab your coffee, tea, or drink, depending on where you are and in which time zone. And let's start it. Thank you so much.
Wonderful, Gagan.
Okay, fine. So just on the group, we have 4 groups. The first group is more of the Asian countries and some of the English-speaking countries from the MENA region. The second group is the French-speaking countries of Africa. The third room is the English-speaking countries of Africa. And the fourth is the Portuguese and the Spanish-speaking countries. So to choose the group, you go to the bottom of your screen. That would be showing you a breakout room icon as seen in the slide. And then you can choose your room depending on where you want to be. And it's 40 minutes for group work. And after the group work is over, you will be guided back into the main session. So if we can leave this slide on the screen when people are taking a break, it will be easier for them to do it. And Olive is there in case there's any problem. Olive will guide you for the next steps. Thank you so much.
Great, wonderful. So break until, let's say 7 minutes after the hour, and gather back and go into the breakout rooms. Thank you all.
We are back. We have
Yes, we are back.
162 people, so we can start.
Okay, so maybe we can project the slide that was there earlier. I don't know, Olive, who was showing a slide.
Yes, Rajiv. Dr. Harris is going to show his own slides, but can you project the slide to show the next session, please?
Yes.
Over to you, Rajiv, to introduce.
Rajiv, I think you're on mute.
Oh, my apologies. I was talking to myself.
Okay.
I said, welcome back, all of you. Can you hear me now? Yes.
Yes, we can.
So welcome back. And we had this group session. Thank you for your participation. And we will use the outputs of this group session in the report and in our discussions tomorrow. We are now going to move into some special things like newer learnings, innovations, etc., or considerations that we need to kind of keep in mind as we think about scaling up the sick and small newborn or sick or small newborn care in our countries. We are going to start with two presentations. Hopefully, we will be able to finish them today and then have a brief question-answer session. If we are unable to do that, we will have to shift some of it for tomorrow. Hopefully, we can do it. So I'm going to ask, first introduce Dr. Harish Chalani from Vardhaman Mahavir Medical College in Delhi. He is the in charge of the newborn care unit, has several years of experience, and has been working with sick or small newborn care in India for several years now. And he was a principal investigator of one of the studies on immediate kangaroo mother care, in which this concept of mother newborn intensive care units or mother newborn special care units was evolved. So without further ado, I will ask Dr. Chalani to share his slides and make his presentation. And Dr. Chalani, please try to finish it in the next 15 minutes. Thank you.
Rajiv, can I be made the host to share the slides? I can't start the screening, sharing.
The slides are there if you want. Her can do that. Please continue.
Okay. Can we take it to the full scale?
Sorry, I think it's the full screen already. So
yeah.
Dr. Harish, you are now a co-host. You can share your screen if you wish to. It might be easier for you.
Okay, Okay, thanks Raji for giving the opportunity to share the concept of mother neonatal intensive care unit. What I next in 15 minutes going to discuss how this concept of mother newborn care unit came and what are the benefits of this. So what is mother in NICU or mother newborn care unit is a facility where the small and sick newborns are cared with their mother 24/7 or the facilities of level 2 newborn care unit and provision of the postnatal care to the mother. So it is very important that we are having a level care that is of level 2 care, including the CPAP, and there is also a provision for postnatal care to mothers. Now, this is an important, the Donald Wincott, who is the pediatrician and who was the psychoanalyst, says that there is no such thing as a baby, there is a baby and someone. So I think what he was probably referring to a smooth transition of mother and baby together in the intrauterine life to a more closer, physiological way of keeping the mother and baby together. So when I say mother in NICU, is it just an emotional concept? Because we have got the experience from some of the developed nations, Sweden and Norway, where the mother and baby are together. So are we talking just of the emotional concept, or does it have hard objective benefits? So what I'm going to make a case of the zero separation before you all. We all know that the global burden of low birth weight babies, and most of these deaths, they are occurring in the neonatal period. And not only, they have the issue of the increased mortality, but also those babies who survive, there are challenges of the growth retardation and the developmental delay after the discharge. So we also know that for the survival of the low birth weight babies, the kangaroo mother care is a very important intervention. But if we know that currently the WHO guidelines are that KMC is recommended for babies below 2000 gram or less, and only once the baby gets stable. And brief sessions of the KMC is also initiated when baby's condition begins to stabilize. That means once the baby is in NICU, the mother can provide KMC. What we have seen from the Cochrane data of 2016, there is a 40% reduction in the mortality of these babies. But if we also look at the studies, the mean age of randomization was 3 days, and it ranged from 10 hours to 24.5 days. And we also know this fact that about half of the preterm deaths, they occur in the first 24 hours and majority in the first week. So that means before the babies get the benefit of the KMC, we are losing many babies. So the research question which came, does the continuous KMC, if initiated immediately after birth, compared with the current guidelines of that is starting after the baby becomes stable, improves the newborn survival. So with that research question, a multi-country randomized controlled trial was initiated to see the impact of continuous kangaroo mother care when it started immediately after birth. That was the intervention compared to the control group, that is the standard care which we are practicing in the population of babies with birth weight of 1 to 1.8 kg on their survival. The mortality we looked at 72 hours and 28 days mortality. And included singletons, twins, and babies both born by vaginal deliveries and cesarean section. And this study was done in the 5 countries. So this is what we generally see the standard care, where the KMC is initiated after the baby is stable, and after that baby moves from NICU to the KMC ward. But the intervention here, it was that continuous skin to skin contact with the mother or the baby started within 2 hours of the birth, with the aim to as high as 20 hours per day. Along with that, support for the exclusive breast milk feeding or breastfeeding, and provision of required medical care, because we are keeping mother and baby diet together. So the postnatal care for the mother also to be looked at it. So with this intervention, we had to create an unit where mother and baby can be made together. So what you can see here is that there is a radiant warmer, there is the oxygen, there is a suction, there is a CPAP unit, and the mother is next to the baby. And so this is the, you can see that what is the 12-bedded unit. So from that, we have got the picture of 1 unit. So it has got the level 2 care. There is the adjustable bed with the back support. There is a heater and there is a CPAP unit. So as I was mentioning, it was a level 2 care along with mother's bed. What is actually is that it is an increased opportunity. Before that, the MNCU or the mother newborn care unit has got the ancillary services and the toilet and the bathing area for the mother. And since mothers, they are immediately after the delivery, the obstetricians come take the round of these mothers. So the separate examination table for the mothers was also created. I'm not able to the slides. Can you hear me?
Yes, we can hear you.
Yes, we can hear you.
Okay, yeah, sorry, now it's okay. So what this mother newborn care unit offers is increased opportunity to provide KMC, because conventionally what we see, that mother comes intermittently, and even in the day times we have seen average time when she comes for 3 hours, and the KMC which is provided is for 1 to 1.3 hours. So here it is increased opportunity for the mother to provide KMC for as long as possible, because she is with the baby 24/7. And it has been seen that mean duration of KMC, even the respiratory support, was 17 hours per day. And there was increased opportunity breastfeeding. The mother expresses the breast milk, and the same milk is given by the tube feeding in the KMC position. Since the mother is with the baby, she is involved in the care of the baby, she changes the diaper, she even monitors the baby and even talks to the baby and providing a developmentally supportive care. Now, because the mothers are together, there is a better understanding of the preparedness of the various care. In fact, the mother who has come earlier, she becomes the facilitator for the other cases, and you can see that the counseling and preparedness is there. Now, what we have found is that mothers can be easily trained to follow the asepsis routine. There is increased support for the breast milk feeding. There is a less anxiety, and there is a better satisfaction amongst the mothers. And staff, initially we were thinking that they are being, accountable by the presence of the mother. But actually, if we have seen, they have got the less workload, because most of the tasks have been taken care by the mother in these units. Now, coming to this,
I think we lost him.
Dr. Harish, you are muted.
Yeah, he's lost.
Dr. Harish, you are muted.
He's muted.
I'll just it's the lost actually. Yeah. Sorry for the delay. I'm extremely sorry. Yeah, so coming to the results, the mean birth weight in the study was 1.5 kilogram. and the mean gestation was 32 weeks, and you can see that around 34% of the babies were born by the cesarean section. And we see that mean of the skin to skin contact in the intervention group started as 1 hours, whereas in the control group, it was as late as 53.6 hours. And if you see the duration of the KMC, while the baby is in the intervention or NICU, there was a striking difference. This almost 17 hours in the intervention group, and after the babies, they got stabilized, then in the KMC ward, it was almost 19 to 20 hours. Now we also look at the area of 70% of the babies were transported in the KMC group. Of course, majority of them were with the surrogates because the mothers were required to be observed by the obstetrician. But important thing is that KMC transport was efficacious because 98% of the babies were shifted when they arrived at the nursery, they were euthermic. And when we looked at their saturation, so they were less chances of the desaturation, there were less severe chest indrawing, and there was less grunting when these babies reached the nursery or the Mnicu. Now, when we looked at the primary and the secondary outcome, looking at the death at 28 days of life, the risk ratio was 0.75. That means there was 25% reduction in the mortality between the intervention and the control. In fact, the difference was so striking that data safety monitoring had to stop the the trial at 75% of the enrollment. One can see that there was 35% reduction. There was better maintained temperature in the intervention group. The hypothermia was less, and the sepsis was 80% less. The mean score for the maternal satisfaction, because these babies, they shift to the KMC, they were high in both the groups. Now we also had the additional breastfeeding indicators. So we looked at those babies who were in other NICU group, their breastfeeding initiation, reaching to 7th or on discharge in the exclusive breastfeeding were much higher as compared to the control group. Now we had the changes in 07, initiating the in the room.
Colleagues, we seem to have had a break. Dr. Harish, can you hear me?
Dr. Harish is muted.
I think it is interrupted. Even while he was presenting, it was interrupted while he's speaking.
Yeah, I think he doesn't have a good connection.
Yeah, so can you show the slides from where
no, he's back. No, you are muted, Dr. Chilani.
Thank you. If you could show, yeah, and maybe if Dr. Harish could continue presenting with us showing the slides, it might help. I think it's a bandwidth issue. Yeah.
Dr. Chilani, can you hear us?
Hello. Yeah, I don't think he has a good connection. Can someone see him?
It looks like he has lost connection.
He's dropped, yeah. I think he has dropped. Can
Oh.
somebody go through the slides from the team?
Yeah, I mean, that's fine. We can I could present them on his behalf. So where were,
that's what I was suggesting, Dr. Rajiv, you can take over.
Yeah, that's fine. So what, let's go on to the next slide. So the experience of the mothers and staff on the MNICU, he already spoke about that the mothers were easily trained. There was more support for breastfeeding. Staff has let work. Move to the next slide, please. Yeah, next. He's already shown these. Yeah, the initiation, next. Yeah, the most important point here to note is that the mortality was lower in this group that had the MNICU or the immediate KMC by 25% compared to those with standard KMC. So both groups received KMC, but the group that started on KMC earlier had a 25% reduction in mortality over and above what the effect of the KMC was. There was also a 35% reduction in hypothermia and, very importantly, an 18% reduction in sepsis. There was a concern earlier that people thought that if mother is allowed in the NICU, we may see more infection. That's not true at all. You actually see less infection when the mother is taking care of her own baby rather than others taking care of the baby. Next. Next, breastfeeding was improved. So I don't need to go into each slide, each of these indicators, but of course, the opportunity when you keep mother and baby together, there is so much more opportunity of putting the baby to the breast and not going elsewhere to find expressed breast milk, etc. So all these indicators improved tremendously. Next. So what were the challenges in doing this? The biggest challenge is that how do you get the mother who is just delivered to come to the mother newborn ICU, and therefore the support of a surrogate in this early period is extremely important. So one important thing is not only do you need to initiate KMC early, which means in the labor room or the operation theater before the baby is transferred. If it is possible to transfer the mother and baby together, great. If not, then a surrogate was used to transfer the mother and baby, transfer the baby, and the mother followed when she was ready to come to the MNIC. Creating a mother and baby friendly infrastructure, as Dr. Chelani was mentioning earlier, that the tech required everything that took care of the mothers was extremely important. Optimizing respiratory support in KMC position, because one of the things people think is, oh, this baby requires oxygen or CPAP, so we can't give KMC. That was not true. In this study, all the care was provided in KMC position. Monitoring for asepsis, infection control, coordinating with, now this is something which was being also raised earlier in the chat, that the obstetrics or maternal health team, their role in providing this combined care for the mother and baby is extremely important. We are very used to pediatricians going into the postnatal wards where mothers are kept. But obstetricians usually don't come to the newborn care units. Here, the obstetricians were providing care to the mothers within the newborn care unit. So they were being cared for as a dyad by a team of both obstetrics or maternal health people, as well as the newborn health people. Next slide, please. So this is what we are talking about, the issues of initiating skin-to-skin contact early, designated IKMC area, initiating with surrogate. I've spoken about that. Next slide, please. Then we are talking about transport in KMC from labor room to mother NICU. You can see the pictures. Next slide, please. Optimizing respiratory support in KMC position is one of the challenges. Maintaining the airway. So there was a binder that was used to maintain the neck in a slightly extended position. Optimizing nasal interface for continuous CPAP or CPAP, continuous positive airway pressure. Major challenges is ensuring that the fixing of this, of the cannula is good, so that with slight movements of the mother, the cannula doesn't come out. Also, there was a continuous monitoring of SpO2 and heart rate with a simple pulse oximeter. So not a big cardiac monitor or anything, but a pulse oximeter that would continuously measure SpO2 and heart rate. Next. These are the garments that were used so that the mothers could use them if they wanted. Next. Does it increase infection? We know absolutely not. I told you we had 18% reduction in overall in all sites, and only one site was in India. The remaining sites were in, as you've seen, in Africa. Next. So caring for the mothers in MNICU is a major challenge because they have just delivered. We didn't want them to have any risk in terms of postpartum bleeding or any other issues. So an essential care package was developed for immediate postnatal care for the mothers. The neonatal nurses were trained to provide that care to the babies, but also the obstetric team, now, as I had earlier mentioned, came into the NICU and actually took care of the mothers on a daily basis. So this equal partnership and strong collaboration between the maternal health team and newborn health team is a must. Next. Zero separation of small and sick babies means that we can achieve high hours of immediate or kangaroo mother care, which is, we know, is extremely efficacious. There's a 25% reduction in mortality. If you are able to translate that, that's an additional 150,000 lives saved with KMC over and above what KMC after stabilization does. Zero separation is safe, no increase in sepsis, in fact, reduction in sepsis, hypothermia, hypoglycemia, and is acceptable. We were very surprised of the positive feedback from everyone, parents, the nurses, everybody was so happy. In fact, I have to tell this story in a minute, that the first time we went to train the people in Safdarjung Hospital, the mother was brought into the NICU and everybody was apprehensive. All the nurses were, kind of looking what will happen. The mothers not come inside. And this baby was put skin to skin with the mother, and the mother started crying. And everybody thought that she is very stressed and she is very emotional and it's something wrong. So everybody was kind of, what happened? And she said, you can't imagine how de-stressed I feel. I was in so much stress for the past 24 hours when I was separated from my baby, didn't even know what is happening to my baby. And just feeling him with me is such a big relief. Next. So Mother NICU has continued in the COVID pandemic with, of course, the masks and all the other issues that need to be taken care of. Next. So what are the implications or in terms of system challenges? So most of it is self-created. We have created policies which don't permit mothers and surrogates to be in the NICU 24/7. So you create the
policy that is supportive of that. And then the mother NICU itself has to be created. So in Safdarjung Hospital and in Tanzania, they built a new unit, but in the other centers, they converted the unit into the Mnicu, part of the unit into Mnicu. Thank you. Next slide, please. But we definitely believe that this is a revolution in the way babies and mothers could be treated. We had created ourselves this separation of mother and baby earlier, which was corrected for term babies and healthy babies with the BFHI, with breastfeeding hospital initiative. But even then, we left the room open for if the baby is sick or small, they should be separated. And we don't think that is right. With this evidence, it becomes quite clear that mothers and babies kept together would actually be, and this we think is again one of the next level of family-centered or family integrated care, because we are talking about now the mother being with the baby or a surrogate with the baby 24/7, and also another person to help the mother provide KMC to the baby. Next. Yeah, so we've already talked about this couplet care issue of both obstetricians and mother, minimal care for mother and baby both, conviction of the health workers. Next. So that's it. Thank you very much. The slogan that Dr. Chelani and his team have here is that mother is a care provider and not a mere visitor to the NICU. Up to now, we have used mothers to come to the NICU, sometimes be with the baby, sometimes do a little bit of breastfeeding or KMC and then go back as a visitor. But here, she is actually the main care provider. She is the one who is taking care of the baby, changing the diaper, changing the clothes, making sure the baby is fed, etc. And only the medical care is provided by the nurses. Thank you very much for your patient listening, and I'm very sorry that Dr. Chelani could not finish his presentation.
I'm sorry, I've joined back, but there had been some serious issue with the net, so finally got settled. So I'm really sorry.
Sorry,
but,
back to you then, Dr. Chelani, if you want to make any comments. I took the liberty.
No, I was just saying that, the best physiological transition can be, and as you mentioned, there is a lot of stress onto the mother as well as the baby. And initially we had a lot of our own, convictions and apprehensions that whether we would be able to give surfactant in front of the mothers, whether we can transport the mother in the CPAP, in the KMC position. But I think the parents are ready. It is the healthcare providers' apprehensions which are there. Mother wants to be with the baby. And recently we had the team from the National Geographic Channel, and the mothers explained that we are so happy in this unit, and otherwise, because they told the experience of their previous baby in the Mnicu also. So this just want to say that in the end, that we had been separating the baby and the mother for decades actually. But now with the new evidence and the science which is available with us, we should keep them together. This will improve the opportunity for even for the stable babies for the KMC. In fact, 80% of the babies in the NICU are those for assisted feeding, mild respiratory distress. They are not critically sick. So even we can start with those babies, keeping them together. And as and when more confident, we can keep the sicker babies also.
Yeah, thank you very much, Dr. Chelani. We are 18 minutes over time. So I'm going to say that we stop this presentation. Just one point I wanted to make is that if anyone from the African sites is here, Tanzania was Muhimbili, So it was Karim, and our late Dr. Masawe was the, Augustine Masawe was the PI for Tanzania. We also had Ghana in Kumasi, the medical college at Kumasi, which had the same intervention. We had, in addition, Nigeria, Ile-Ife. So if any one of you is here, please do wave. And also the Malawi site, Dr. Queen Dube and Kondwani Kwaza. So this is, I would like to propose that we stop today here. And I'd like to just ask Dr. Karen Walker if it is all right with her, because otherwise I think we would go far into the next hour. We are already losing participants and people might have other meetings. So Karen, if I could ask you if it's okay if we move your presentation to tomorrow morning.
That is absolutely fine with me, Rajiv. Thank you.
I don't want you to rush through it because human resources are such a critical issue in terms of the newborn care units, that we would like to do it when we are fresh and we have some more time.
Right. And also we are now 127 participants, Dr. Rajiv. It will be good to have the 200 plus, which we were having in the beginning. So
I agree. So I would like to thank everybody for today. Thank you for your participation. Thank you for your questions. We will have the question for Dr. Chalani tomorrow. So Dr. Chalani, please do join and you can see the questions in the chat box that are already there. So that would be the end of day 2. Thank you all. Enjoy your evening, afternoon, wherever you are. And then we will see you tomorrow.